Hey everyone, good morning. Let me know if you can hear me or not. All right, fantastic. We'll get started here in just a few minutes. Yep, if you guys have any questions, go ahead and post them up on the sticky board or in the chat. We'll go ahead and take care of those. Or if I seem distracted, I was dealing with a student issue. Although I will tell you that I had my eval review with your program director, and we went ahead and I'm gonna turn my mic down just a hair. Went over your guys' evals from the summer. And one thing I just want to note is that I really appreciate your guys' evals. So good, bad, or indifferent. If you could provide those, I really appreciate it because there's 30 of you, and I think we only got like 14 that were in. And so I really take those to heart. I really try to improve the course based on what you guys tell me. And so more info is better in those cases there. So I really implore you. That's a word I'm going to use because that's how strongly I feel about it. I implore you to please provide evals. Again, if you hate the class, if you love it, whatever, I'll take it all. I do appreciate the random reviews I get that are particularly salty and or spicy. Those are pretty fun. Someone said that, and it's funny because, I keep all my YouTube videos open, so, you can go back years and even see what I was doing back then. I can tell some people were watching videos that I've done between, you guys and Nova, and someone's like, well, you seem like you're more awake for them than us. I thought it was funny. I was like, well, you try getting up at 8 o'clock and giving a lecture every Friday. It's kind of tough, but So, Dr. Whitaker suggested that he supply me with Monster energy drinks to maybe increase my energy levels for these morning sessions here. So that's one improvement we'll try to make there. I don't have a Monster today, but I'll try to do my best to muster up some extra energy. But it's 8 o'clock, so let us begin. All right, so let me go ahead and switch over here. I want to check out the... Oh my goodness, my Chrome window's not working. Let me fix this real quick. I wanted to look at the sticky board. Dun, dun, dun. Here we go. All right, you guys should be able to see that. All right. So someone had the question that said, are salicylates in the same are the same as NSAIDs, or is aspirin the only salicylate and the rest are NSAIDs? How can I categorize this info? Also, what's the difference in glucocorticoids and corticosteroids? I'm getting a little confused since I know we've seen them in derm and ophtho already. Are we just talking about different routes of administration when we move on to their use in another system? That's a good question. So, in terms of salicylates, yeah, their mechanism is identical to the NSAID. So if you want to categorize them based on their mechanism, then yeah, they're the same. The only difference would be that, their side effect profile is fairly different. Like we talked about, like the Ray's syndrome being unique to aspirin. The antiplatelet effect is going to be a lot longer for aspirin, because it's an irreversible inhibitor of cyclooxygenase. You'll find that it lasts for, the lifespan of a platelet. So like 7 to 10 days versus things like ibuprofen is going to be reversible. As soon as the drug is out of the system, it goes back to normal. So that's one of the big differences there and why I sort of break them out. Also, in terms of toxicity, they are quite different. If I have someone who comes in for an ibuprofen overdose, not too worried about that patient unless they took a massive amount. However, if someone took a aspirin overdose, that can go south pretty quick. So I keep them separate in my mind, but if you want to lump them together in terms of mechanism, that's reasonable. However, I would suggest you do delineate based on their side effect profile and their uses, because you're not going to see someone use an NSAID for cardiac protection, for preventing MI or something, as opposed to aspirin, where that's one of its main uses, right? So the other thing was, someone had a question about our talking about glucocorticoids and corticosteroids and all that. Am I talking about the same thing? So the way I'll talk about them is sort of how you break them down, right? So when you're talking about corticosteroids, right? So I'm going to do a little drawing here. So corticosteroids, you can kind of break them down into two main categories here, right? So you have your glucocorticoids, and then you have your mineralocorticoids, right? And cortisol, which is your main sort of glucocorticoid that your body produces, falls into that category. It's a stress hormone. Most of you probably release it before test time and things like that, or just at a constant basis, probably based off of just being in PA school. But it regulates glucose. It affects the immune system, immunosuppressant, decreases inflammation, all of that. Those are your glucocorticoid effects. The mineralocorticoid effects, the main one that your body produces is aldosterone. And so aldosterone is really important for affecting water balance in the body. It affects things like salt retention in the body. We'll get to that later when we get into cardio. And so it's important to delineate between those effects, because the drugs that we administer, things like dexamethasone, prednisone, etc., they can have a balance between glucocorticoid and mineralocorticoid effects. So you may find some are more heavily just glucocorticoids. Some may have a blend between that and the mineralocorticoid effects. So for instance, like hydrocortisone, which is for all intents and purposes cortisol, like your body produces, has a pretty decent balance between the two here, versus something like prednisone, which you might take for an allergy exacerbation or something, is much more strong on the glucocorticoid effects. But you'll still see some of these mineralocorticoid effects. So for instance, if you have someone who is taking prednisone, they can notice some weight gain. And a lot of that has to do not just with like their blood sugar changes, but more often acutely has to do with their fluid retention. So they can cause some edema and then cause some weight gain associated with that. So that's why it's important to kind of keep in mind these two different effects, and that's what I'm talking about. So corticosteroids is the overarching umbrella. The two categories underneath that, glucocorticoids and mineralocorticoids. So hopefully that makes a sense. Let's get back into talking about the PowerPoint here. So, and again, if you have further questions, just let me know. I can go ahead and check those out. But getting into it, let's talk about our pulmonology drugs here. So first off, I want to talk briefly about some antitussives and expectorants. Basically, and I think we talked about expectorants last time, but regardless, here's our antitussives. These drugs are going to work to basically block the cough reflex that can occur in the body, and this is usually in response to some sort of chemical or mechanical irritant, which can affect the respiratory tract. And so you have these receptors here that have a pretty complex reflex mechanism that affects the medulla, and basically you'll have this kind of this whole concerted sort of effort to, you inspire a big breath, and then you close the glottis and you contract the chest walls, and you force all this air out at one time to hopefully get rid of whatever that irritant was in the first place. However, it can be problematic to your patients You can find that can lead to insomnia and exhaustion if they can't get a good night's sleep. And even some rare cases, it can worsen dysrhythmias and has caused stroke before, but fairly rare in those instances. So, what do we want to do for those patients? Hopefully, we can reduce the number and severity of their coughing episodes and prevent any sort of complications like being kicked out of bed by your significant other. That would be probably a pretty good goal there. So I'll talk about benzonatate or Tessalon pearls first. Tessalon pearls is sort of the dosage form. You can see how they get their name, pearls there. These are always, I always hated these in the pharmacy the few times I worked in the retail pharmacy because they kind of go everywhere. You know, they have that little tray that the pharmacist will use to dump out the pills, and they count them by fives into the bottle. These things will fly all over the place, and so you can invariably, in most pharmacies, you'll find a Tessalon pearl probably on the floor in the corner somewhere. Because they're pretty slippery. But regardless, these are useful because they actually help to anesthetize the stretch receptors in the lung. So that way, if you did have an irritant or something come along, it just really wouldn't affect the lungs that much to where it would cause a cough in the first place. And so you can use this as an as-needed sort of basis there. Okay, no problem, Katie and Megan. So basically, you can take this on more of an as-needed basis. If they're having coughing episodes, this can be beneficial. One thing you want to note here is that you do not want to chew on these. And this is more of a problem of like kids getting into it on accident and things like that, because they do look kind of like candy. But if a patient were to chew into this, it can actually cause anesthesia in the mouth, which is, you know, kind of an odd feeling and something you don't necessarily want, because then also it's not going to work in the respiratory tract where it actually needs to work. So no cutting, crushing, or chewing of the Tessalon pearls. For the most part, though, fairly safe. Not a whole lot of side effects other than that if you chew into it. Next up, we have dextromethorphan, often known as Robitussin or Delsum. This is a pretty common over-the-counter antitussive agent, and this actually works through these sigma receptors that you have in the medulla. And so this is actually related to codeine, which codeine is an opioid analgesic. And actually one of the things you'll see with all opioids is they tend to have an antitussive effect. So things like morphine, things like Dilaudid, things like that. Even fentanyl could be used as an antitussive drug. However, that's pretty overkill, and there's a lot of side effects associated with that. So we don't do that frequently. Instead, what we can do is use something kind of related to that, but it doesn't really trigger those same opioid receptors to cause CNS depression and you know, analgesia and potentially addictive properties. So dextromethorphan kind of fits that bill. It's related to codeine, but doesn't activate the same receptors here. Mainly used for cough, though. However, the side effect profile is kind of interesting because you can see, and if you've ever heard of the term robotripping, has to do with abusing Robitussin, because you'll typically see, like with adolescents who are abusing medications, it's going to be things that are easily available or cheap. And so over-the-counter medications like dextromethorphan you can buy bottles of, and most people will not give you a side eye unless they kind of know what's up. So people can abuse this in high doses to cause hallucinations and all kinds of fun stuff, except for, you know, it's pretty nasty in terms of side effect profile. Can cause agitation, can lead to seizures, can be really difficult to manage those seizures too when they occur. So I certainly would not recommend anyone abuse dextromethorphan for these properties. There also is some risk of having serotonin syndrome if you mix it with other pro-serotonergic drugs. This is mostly going to be your antidepressant medications. I'll focus more on this when we get into behavioral health next semester. So just know that this is a risk you could have with that. And just avoid taking with any drugs that block MAOI. This is kind of similar to linazolid when we talked about Zyvox last time, or back in the anti-infective section there. So just one thing to note with that. So, all right. So moving on, let's talk about some pulmonary antibiotics. Again, the benefit here is I don't really have to belabor points about, you know, mechanisms and side effects of the drugs and all that, because you already know them, right? So let's get into talking about bronchitis first off. Of course, this is inflammation of one or more of the bronchi. You're generally going to find that this can be caused by viruses and things like that. Certainly, you can have chemical irritants, which can lead to bronchitis, but in some cases, you're going to find it can be related to bacteria. And so, of course, you know, acute bronchitis kind of affects everyone, you know, all ages there, but with chronic bronchitis, this is more of a case where you'll find it with COPD patients. We'll talk more about that later on here. But again, not really affecting the alveoli and the bronchioles, so kind of a little bit higher up in the respiratory tract versus the very distal ends there, which we'll talk about that when we get to pneumonia. So as I mentioned, a lot of viruses that can cause this. So rhinovirus, coronavirus, which I don't know if you guys have watched the news, but there's some interesting updates there. I personally can't wait for 2020 to be over. It'll be nice. But the other thing, too, you want to consider from the bacterial side, and again, sometimes you'll find that viral cases can lead into bacterial cases, but things like atypical bacteria like Mycoplasma, Chlamydia, and Bordetella can do this. And then you can find a lot of your more frequent offenders in terms of respiratory tract infections like strep pneumo and Haemophilus influenza, even staph can sometimes be causative here. And so those are things you want to think about when you're trying to come up with your list of antibiotics to use based off the bugs that are likely present. Generally, though, if you're thinking it's more viral, symptomatic supportive care are fine, right? So if they have a fever, give them antipyretic, acetaminophen, ibuprofen, something like that. If they're having excessive cough, then give them something like dextromethorphan potentially. So those are the big things you want to focus on. Typically, you want to avoid if they're having any kind of productive cough. It's okay. You want them to get rid of that stuff. You tend to find if you're using things like antihistamines or sympathomimetics like pseudoephedrine, that you can actually dehydrate the bronchial secretions, and that actually kind of leaves all that gunk just sitting there in the lungs, and that can actually prolong symptoms. So it's okay if they have some drainage. It's not the most comfortable thing for the patient, but they need to get rid of that stuff, basically. So typically, antibiotics are not recommended for this because such a large proportion of them tend to be viral in nature. However, doesn't stop a lot of bad providers there are good providers and bad providers out there, and hopefully I'm training you all to be excellent providers. And so you won't just give an antibiotic prescription to everyone who walks through the door with a cough and mild fever, right? However, though, if they're having symptoms for, say more than 5 days or so, you want to start to consider bacterial involvement. And so here are some drugs you can consider using here. Due to the number of cases that you'll find being caused by atypical bacteria, that's why you got to kind of change your treatment around, as opposed to like something like an otitis media, where you could focus on, gram-positive, gram-negative, strep pneumo, H influenza, things like that. Here, the propensity to see atypical bacteria mean that you need to focus more on drugs that cover that. And so this is where your tetracyclines and your macrolides come into play here. So for instance, like doxycycline is totally fine. It's going to get most of the gram-positive we talked about. It'll get H flu, but it's going to get the atypical bacteria that we mentioned, Mycoplasma, etc. This is going to be preferred if you find that there's a high degree of macrolide resistance in Mycoplasma. So that is going to be very much dependent on sort of where you're working and sort of the geographical resistance patterns there. But certainly macrolides are going to be used probably most commonly here just because it's super easy to dose this. You just say Z-Pak uses directed and you're done. Can't get much easier than that. Not to say that's the best thing ever, because you should know how you're actually dosing your medications, not just basing it off of uses directed sort of thing there. Any of those are fine. In terms of respiratory fluoroquinolones, I probably wouldn't use these unless you had some recent antibiotic exposure, mainly because of that can have a tendency to select out for more resistant strep pneumo. And so unless that's a risk factor, then I wouldn't want to use our fluoroquinolones, just because from a toxicity standpoint, they're a little bit worse than you're going to see with something like a macrolide. And also, you have to worry about drug interactions, which is still a concern with macrolides for sure. But also think about things like resistance becoming more prevalent towards the fluoroquinolones. If you can hold back on that, that's going to be preferential, And again, too, you still have to know everything about these drugs we talked about before. So you still need to know like what kind of patients you don't want to use fluoroquinolone in, or which kind of patients you may not want to use a tetracycline in. So go back and review that stuff, because it's still fair game for a test question where I could say, hey, you have a 23-year-old pregnant female coming in. She's, 36 weeks gestation, and she has bacterial bronchitis, or you suspect bacterial bronchitis. Which one of these would be contraindicated? And so you'd have to be able to say, okay, well, looks like, doxycycline probably would be a bad one because you don't want to give that to, women in the second and third trimester. So stuff like that is you want to clue in. Because again, it's easy to know what the first line choice is for a particular indication, but you have to take into account the patient factors. That's why medicine is an art more so than science in a lot of cases, because you're looking at what's the past medical history. You're looking at what other medications are on, what could be interacting, all that kind of stuff that goes into selecting the right drug for that particular patient, right? All right, moving in, next we have community-acquired pneumonias. And so again, when we're thinking about pneumonia, you want to think about your natural defenses that we have against that. And so getting down into the very distal ends of the respiratory tract here, we'll see that the airways are sort of covered with these ciliated epithelial cells, which you can see here, and their whole job is to sort of have a concerted effort to get gunk out of the lungs and kind of move them up along the respiratory tract where we can cough it out and get rid of it. And so it keeps things relatively sterile, which is pretty beneficial. However, there can be cases where this sort of sterile environment is disrupted. So for instance, if you have someone who maybe has been smoking all of their life and they have obliterated these ciliated cells and replaced them with more fibrous tissue, or if they're not producing mucus effectively. We have some patients who have cystic fibrosis and they have problems producing mucus that is they basically produce mucus that is super viscous and it doesn't really go anywhere, and so they actually harbor a lot of bacteria because they can't get rid of that stuff. We can talk about that later for sure, but so a lot of things can happen here that may make your patients more predisposed to pneumonias. So we say it's sterile, but how do microbes actually get in here? You can see this in terms of like aspiration from the oropharynx. So you can have some bacteria from the GI tract getting into the lungs there, which is relatively common in elderly patients who may have degrees of, CNS depression. Maybe they're not protecting their airway like they should, things like that. Or if you have inhalation of an infectious aerosol, so you're around your buddy and they start coughing in your face or something. One thing you also want to consider, though, is you could have a hematogenous dissemination. And what does that mean? But you have an infection at a different source and it spreads through the blood to the lungs, which can happen with even things like UTIs, right? You can have a urinary tract infection that spreads hematogenously in the blood and can eventually end up in the lungs. So that's something you can see too, especially in elderly patients or those who have immunocompromisation or something like that. Or you could just have direct inoculation, so just directly putting bacteria into the lungs themselves. And so, trauma can be a case where this actually occurs here. So you have like a penetrating knife wound or a car accident or something like that that can lead to that. Generally speaking, though, I'm not going to necessarily ask you questions on diagnosis, right? Because you're going to get that in your other courses. I'm not the expert on diagnosis. Your other professors are for sure. However, I'm going to say, okay, you have a patient and you strongly suspect they have community-acquired pneumonia. What drugs can be best for them based on allergies and based on other medications they're taking, based on their history and things like that. So that's what I want you to know, right? Typically, though, for outpatient management, the patients are well enough to be treated on an outpatient basis. Empiric antibiotics are fine. You typically don't need to do diagnostic tests, meaning you don't need to get like sputum cultures on them necessarily. You can just sort of go with empiric antibiotics, which I'll tell you what those are in just a moment. For those that need to be hospitalized, if they're that sick, then typically you want to make sure that you're getting blood and sputum cultures, right? Blood because maybe this was something that was a bacteremia that has spread to the lungs and could be infecting other parts of the body, so you want to look out for that. And then sputum cultures as well, right? These may not be perfect, right? Because you can have contamination and whatnot, especially in the sputum cultures. If you see like a lot of epithelial cells in those cultures, chances are you just got a good sample of spit. And so you're seeing more mouth stuff than actually what's down in the lungs. Sort of the best thing for that would be to do a bronchial alveolar lavage, but that's much more invasive. And so that's not done for your routine hospitalized, cat patients. You got to do this before antibiotics. And so I really want to stress this point here, because what happens if you don't, well, you could kill off, if you give antibiotics first, you can kill off some of those bacteria. And so it may make it difficult or impossible to actually culture out what was growing there. And so that makes it very difficult to know whether you selected the correct antibiotics or not. But again, using that sputum, gram stain, and culture, it's, as I mentioned, frequently contaminated, and you may not actually get the responsible pathogen. If it was an anaerobic bug and you didn't get an anaerobic culture, then you're not going to grow anything. So there could be some cases where it's not going to be perfect, but sometimes better than not. And there's a lot of means of determining, does your patient need to come in-house? Can they be managed outpatient? Do they need to go to the ICU? I'm not going to get into all that because that's, again, outside of my wheelhouse, and your other teachers will certainly give you more clues on that. But I do want to talk about the etiology in terms of thinking about what type of bugs are likely to be here. So what do we see? So outpatient, a lot of the stuff we've already seen. So this is nothing new. It's just a matter of them actually causing pneumonia now instead of something like an upper respiratory tract infection here. So what are the big ones, right? The strep pneumo. We've seen that before with upper respiratory tract infections. Mycoplasma pneumoniae. So you got to cover for atypical bugs. H. influenza, Moraxella catarrhalis, and it could be viral as well, right? So pretty straightforward. So a lot of these antibiotics we're using for outpatient management should look pretty familiar to you as to what we saw for upper respiratory stuff in the ENT section. If they're coming in-house, but they're not sick enough to be in the ICU, you're going to see a lot of the same bacteria here. But then you also have to think about things like Legionella. Those patients tend to be a little bit sicker. Clue for you on the pants, if you get a question about someone, or even on your other test, if you hear anything about an AC unit on a question, it's Legionella every single time. Someone's in a hotel and they're working with a dirty AC unit. They were in a conference hall and the AC unit was contaminated. It's always Legionella, just FYI. So atypical bugs, but still pretty similar to what we see with the outpatient side of things. Inpatient gets a little more interesting because now we have to start thinking about things like Staph aureus here. We have to start thinking about a lot of gram-negative bacilli. So this is stuff like things like E. coli, Klebsiella, Proteus, and even Pseudomonas might now come up on our list here. So depending on how sick they are, that gives us a clue as to how broad we need to go in terms of antibiotic coverage here, okay? So, and what are some risk factors for seeing, specific pathogens here? So for instance, if we're concerned about penicillin-resistant strep pneumonia, what do patients need to have for that to be a concern for us? Well, if they're older, so say greater than age 65, if they've received any kind of beta-lactam antibiotic within 3 months, and all of you should know what those are. So that means any of your cephalosporins, penicillins, carbapenems, anything like that, any beta-lactam in the past 3 months. If they have alcoholism, right, that can lead you to have a higher risk for pneumonia because that can be a chronic sort of light immunosuppressant, but also the CNS depressant nature of alcohol can lead to microaspirations into the lungs. If they're immunosuppressed for any reason, and medical comorbidities, right? So diabetes, renal insufficiency, all of this stuff, right? And then, of course, exposure to kids in daycares, because daycare centers are basically cesspools of bacteria, and so your kids are going to pick up something and come back to you, right? So if you have someone who, say, is a 68-year-old grandma who just picked their kid up from daycare and they come in with pneumonia, you might be concerned about penicillin-resistant strep pneumo, and that's going to lead you, again, to change your empiric antibiotic selection. So what are things that may lead you to think about enteric gram-negative bugs? Well, this is things like residents in nursing homes, which for all intents and purposes is a healthcare facility. They have underlying cardiopulmonary disease like COPD, things like that, medical comorbidities, and recent antibiotic therapy. So again, based on that history, you may want to expand out your empiric antibiotic therapy. And then if we're worried about Pseudomonas, this will be things like structural lung disease. So if they have certainly COPD, if they have things like cystic fibrosis, things like that, corticosteroid use, right? We're just talking about that. Why do we worry about this? Could be because those are immunosuppressants, right? And that could lead us to be more likely to get infected with Pseudomonas. Or if they've received broad spectrum antibiotic therapy for greater than 7 days in the past month, right? So when I say broad spectrum, what am I talking about? I'm talking about things like carbapenems. I'm talking about things like ceftriaxone. I'm talking about, things that treat a lot of different bugs. Because when you do that, you kill off normal flora, and then you increase the risk for things like Pseudomonas starting to populate there. And then malnutrition as well, since that can cause sort of a mild immunosuppression as well. So what do we do? So for CAP, for outpatient management, if they have no risk for resistant strep pneumo, and again, this may be based on local resistance patterns. That's why I always encourage people, wherever you work at, if you're on rotations, you can get a hold of a local antibiogram. That will be helpful because it kind of tells you what the resistance patterns are like in that area. First line though for these patients, macrolide. Go with that. So azithromycin, clarithromycin, Either of those are totally fine. If they could not tolerate that for whatever reason, maybe due to allergy or something, then you can utilize your tetracyclines, so like doxycycline, minocycline. Again, this helps to cover for non-resistant strep pneumo. It's going to get H. influenza. It's also going to get the atypical bugs we talked about, mycoplasma, etc. Okay. If they do have resistance, or you're at risk for resistance, this is where we're going to utilize some combination therapy. So we can either utilize a beta-lactam plus a macrolide. So that would include like amoxicillin plus or minus clavulanic acid, right? So you could use either or something like cefuroxime, cefpodoxime, second and third generation cephalosporin. Perfectly reasonable. So use that plus a macrolide, okay? Those two together. Or you could utilize a respiratory fluoroquinolone. When I say that, I'm mainly talking about levofloxacin and moxifloxacin. Cipro, may have more resistance associated with it. It's not great as a first line for respiratory stuff. So typically Cipro is going to be kind of left off this list here, but there may be some use cases for it, but not generally for kind of empiric therapy. This is good for patients who have like a documented beta-lactam allergy and could not receive a cephalosporin, right? So again, if they have risk for resistant strep pneumo, beta-lactam plus a macrolide, azithro plus amoxicillin, for instance, or a respiratory fluoroquinolone by itself. Okay, so like levofloxacin. So be able to kind of delineate which ones are good options based on if patients have that history of having risk factor for strep pneumo, right? So they got a course of amoxicillin 2 weeks ago. That may make them more at risk for something like this, and maybe a fluoroquinolone might be a good option for them, for instance. Okay. If they are coming in-house, if they're sick enough to require hospitalization, this is where in the non-ICU setting, so they're sick but not that sick, they're going to get an intravenous beta-lactam, so something like cefotaxime or ceftriaxone most often. You could use high-dose ampicillin, something like that. So you get your beta-lactam coverage plus an intravenous or oral macrolide. So that typically is going to be oral azithromycin. So if you see someone coming in for pneumonia, going to the floor, like a med-surg floor, usually you'll see like Rocephin plus oral macrolides. We don't use a lot of IV macrolides for what it's worth. Or instead of that, you could use doxycycline instead of a macrolide if you couldn't, or you could utilize a fluoroquinolone. So again, you're using 2 drugs to cover for all the stuff here, right? So those are your options in terms of covering for that. In terms of ICU, you can generally get away with using the same as above, but all IV treatment. Because again, if they're sick enough to go to the ICU, then you don't really want to worry about having sort of erratic absorption from the GI tract and things like that. And then we also want to consider MRSA coverage if warranted. And so what's your kind of go-to MRSA coverage in the hospital from an IV standpoint? Vancomycin. Almost everyone's going to get vancomycin if you're worried about MRSA, so especially going to the ICU. So, community-acquired MRSA pneumonia is certainly on the rise. We would expect this more so if you were to say, like, looking at the chest x-ray and you saw these cavitary infiltrates, right? Or if they've recently had influenza, that also increases your risk for having MRSA pneumonia. And again, you'll see this as like high yields of gram-positive cocci on the gram stain. That should clue you in that something's going on there, including MRSA on your differential. And so it's generally going to require vancomycin. 99 times out of 100, you're going to start with this. Or for patients who really could not get vancomycin for whatever reason, linezolid, right? And so I have a hospitalist PA coworker who always says, oh yeah, vancomycin 1 gram Q12, pharmacy to dose. And he just lets it go. But it might work in places where pharmacy's not there to dose vancomycin for you. So you got to be able to recognize, okay, what am I thinking about with this? Okay, it's renally eliminated. Got to think about renal function, how they're going to clear this, how often should they get it, etc. So make sure you consider all those things of vancomycin we talked about before, because again, this is not a benign drug, even though we use it like water in a lot of hospitals. You think about the odo and the nephrotoxicity and things like that, right? Okay, so there's also what we call nosocomial pneumonias. This is going to be infections of the lung that basically were not present at the time of admission. So, that's a great question, Katie. Why not Dapto after Vanco? If you recall, if you go back to your lectures, you'll see that Dapto is not able to be used in pneumonias, right? Remember, it gets deactivated by the surfactant in the lung, so it actually does not effective. So very good question. If you ever see someone using Dapto for pneumonia, you should definitely tap them on the shoulder and say, hey, you can't do that. My pharmacy professor said it's no go. And I think most pharmacies will probably not let the order go through. Yep. That's a great point. Thank you for bringing that up. I'm going to assume that you did that just for everyone else's benefit there. You already knew the answer anyway, right? So anyway, so these are infections patients get after being in the hospital for a period of time, usually more than 48 hours. Think again that the hospitals, they're terrible places to get better. If you can get your patient out of the hospital as fast as possible, that's only going to benefit your patients, right? Assuming they're medically stable. Because they can pick up cooties from nurses and providers and everyone else, cleaning people, everyone can bring stuff in and transport it between room to room. So it's a really terrible place to get infections in a lot of cases. There's some cases where you can have outbreaks of really resistant bacteria. That's shut down whole units of an ICU or something, whole wings of an ICU, just to disinfect the entire thing. So move all the patients out, disinfect everything, and then move patients back in. It can get pretty serious there. And again, this is going to include all of your hospital-acquired pneumonias, ventilator-associated pneumonias. And again, why are ventilators associated with pneumonia? Because you have a plastic tube going down your throat, and that serves as a vector for the bacteria to grow in that tube and travel down into the protected respiratory tract, right? So that's a big risk factor there. Or healthcare-associated pneumonias too, right? So think about patients who are at nursing homes and things like that who are chronically in a healthcare environment. They're definitely likely to pick up some of these more resistant bacteria here, right? And this is actually the second most common infection in hospitalized patients after UTIs, right? And again, UTIs, you think about this as being common because a lot of patients have Foley catheters in. And again, that plastic coming into a relatively protected site like the urinary tract breeds bacteria, okay? So you'll see this more in your elderly patients, your mechanically ventilated patients, and is associated with high mortality and hospital costs, right? Think about Medicare and Medicaid, do they want to pay the hospital for an infection that the patient didn't actually show up with in the first place? No, and they frequently don't. So this is why infection control is extremely important in hospitals because, again, it comes down to a dollars and cents sort of thing, right? Also, we don't want our patients to get sicker, so it's also good from that standpoint as well. So here we're talking about healthcare-associated pneumonia. This is typically patients who meet some of the following criteria. So, for instance, they were hospitalized in an acute care facility for more than 2 days in the past 90 days can put them at risk. They're residing in a nursing home or long-term care facility. They've gotten IV antibiotics recently during chemotherapy, which is immunosuppressive. They have wound care in the previous 30 days, or if they are on hemodialysis, right? So if they have chronic kidney disease, renal failure, and they're having to go in for dialysis 3 times a week, that puts them at big risk for this as well. So some things we have in terms of risk factors that are modifiable and non-modifiable. Obviously, if we can do things to fix the modifiable ones, that's going to help us out. But unmodifiable things includes like age, chronic lung disease, if they have depressed consciousness, either due to medications or due to their disease state, large volume aspirations like vomiting and aspirating that, or if they're hospitalized during winter months, it's putting them at risk. And we can't do a lot about most of these here. From a modifiable standpoint, some of these we can do things about. However, some of these are going to be necessary because if the patient can't breathe on their own, then they have to be mechanically ventilated. But things like nasogastric tubes, intracranial pressure monitors, that's not the insane clown posse monitor. They got rid of those at most hospitals. But if you have an intracranial pressure monitor, which is actually going into the CNS, that can be a vector for bacteria to get in. If they're an H2 blocker or antacid therapy, so this is one we haven't really talked a lot about yet, but we'll go over GI stuff later. These are drugs that are used to decrease the acid content in the stomach. And so, why does this put you at risk for pneumonia? Well, typically the stomach is, set at a pH of about 2 because of all the stomach acid, and it's really difficult for most bacteria to grow there, right? So it's typically a fairly sterile environment. But if I give things that increase the pH of that up to something closer to neutral, it gives opportunity for bacteria to grow. And then once they grow in the stomach, they can then potentially aspirate up through the esophagus into the respiratory tract. So that is a risk factor there. They have previous antibiotic exposure or reintubation. All those put the patient at risk, which hopefully we can maybe modify some of these if possible. So that's why it's a big deal to get patients, better, so that way they don't have to be mechanically ventilated anymore, or they can eat on their own, so they don't need an NG tube. But some of these you may not be able to do depending on the patient, right? So what are some of these things we worry about with nosocomial pneumonias? Gram-negative bacilli are going to be a big one, so things like Pseudomonas, but certainly we worry about E. coli, Klebsiella, Acinetobacter, all those things there. So we got to cover for gram-negatives and go broad spectrum here. Gram-positive cocci, so MRSA is probably the most common, although strep pneumonia can also, be a causative agent. And again, the nice thing, if you're covering for MRSA, chances are you're going to cover for most of the other gram-positives as well, which is sort of the side benefit. And then you also got to think about maybe there's a fungus there, right? Maybe there's a fungus among us that's causing infection. So things like Candida, Aspergillus. This is less likely of a problem in patients who have a competent immune system, but it's something to keep on your mind. If patients have been receiving antibiotics for 3 or 4 days and they're just not getting any better, you got to consider things like, like fungal pathogens. You got to consider things like, tuberculosis and all those kind of other things that you don't expect to see in most patients, but could be present here, right? So what do we do? So obviously you want to start therapy as soon as possible. You don't wait on a definitive culture. So what I said before is you want to get the culture first, meaning you actually collect it and send it off to the lab. And then while you're waiting on that to come back, and again, it takes a couple days, you're going to go ahead and start them on antibiotics. So again, your patient might be dead if you waited a lot of time for a culture to come back. It may come back as an MRSA and it's all great, but your patient died in the meantime. So you got to treat soon. So we're going to initiate broad spectrum antibiotics. And so we got to consider multi-drug resistant pathogens here, right? So if they've been living in a nursing home or they're a dialysis patient, you have to consider really resistant bacteria here, okay? And so that means we have to cover for MRSA and Pseudomonas. These are the two big ones I care about. And again, this is why I harped on this so much during the antibiotic section, because this is where it matters, right? It matters for this and sepsis and all those other sort of healthcare associated infections here that can be pretty significant. Once cultures come back and you have an idea of what the bug is, the definitive bacteria causing infection, then you scale back. Then that's why you go ahead and streamline your therapy and maybe only go down to one drug potentially. That's the ideal situation. So looking at this, so let's say we have hospital acquired, ventilator acquired, healthcare associated. These are all kind of lumped in together. These are all nosocomial pneumonias, right? And so then we have to consider, okay, well, how late is it onset, or do we have risk factors for multi-drug resistant pathogens? So, do they have previous hospitalization? Are they on immunosuppressive therapy? Things like that. If not, then we can consider going a little more limited spectrum, and I'll show you what that looks like in a moment. Otherwise, you have to consider really broad spectrum initial therapy for these multi-drug resistant pathogens, right? So if they don't have any risk factors for those MDR pathogens, that we can get away with using something like ceftriaxone, which is a pretty good third generation cephalosporin to go with, or something like levofloxacin or moxifloxacin, so those kind of respiratory fluoroquinolones. If you're more worried about atypical pathogens, that's where you want to end up using these, okay? Or you could use something like ampicillin-sulbactam or ertapenem. But again, these patients are usually pretty sick. Chances are they're going to have risk factors for MDR pathogens. So it's rare you're going to run into patients like this, as opposed to those that are more likely to be at risk for those resistant pathogens there. So instead, what you can do, they do have those risk factors. You can go ahead and use combination gram-negative therapy. So this is a case where you're going to use 2 drugs to cover for Pseudomonas and all the other gram-negatives that are there, right? And normally I told you don't double cover. This is an instance where you do need to do that. So gram-negative combination therapy, including a beta-lactam typically, so anti-pseudomonal cephalosporin, which means piptazo, piperacillin-tazobactam, and anti-pseudomonal carbapenem, so something like imipenem, cilastatin, meropenem, things like that, or anti-pseudomonal, I'm sorry, I got confused there. So anti-pseudomonal penicillin, that's the piperacillin-tazobactam. I was getting ahead of myself. Anti-pseudomonal cephalosporin, meaning cefepime, most likely, right? That's kind of our go-to with that one. So any one of those 3 categories, plus either an anti-pseudomonal fluoroquinolone. So this is where we're going to usually use levofloxacin, maybe ciprofloxacin, or an aminoglycoside. Okay. So again, I will already tell you, there's going to be a test question about this where you have to figure out what an appropriate coverage is in terms of empiric antibiotic therapy for someone with MDR, risk factors for MDR pathogens. It'll be a little old lady coming from a nursing home, a little old man coming from the dialysis center, something like that, and they're going to have risk factors for MDR pathogens, and so you need to be able to figure out what an appropriate regimen is for this patient. People get it wrong every year. I'm telling you right now, it's going to come up. So be able to recognize this stuff, okay? And again, even me telling you that's not really giving you that big of a leg up, because you still have to be able to identify which drugs are going to fit the bill here. So I'll talk about some more detail on that in just a moment. So the combo here, plus something for gram-positive coverage. So typically this is vancomycin in majority of patients. You want to hold off and save linazolid until you have a good reason to use it, such as really unstable renal function where they can't get vanco, or if they have vancomycin resistant enterococcus, something like that. Okay. So, in terms of anti-pseudomonal cephalosporins, we don't like to use ceftazidime because of pseudomonal resistance. So that rarely gets used for this indication here, but most often cefepime, fourth generation cephalosporin. Most of the drugs I'm going to talk about here require renal dose adjustment. You have to watch for this stuff, right? Because when patients get really sick like this, it's not just the lungs that get affected, it's everything. So their blood pressure can be affected. They become hypotensive. What happens when you're hypotensive? Well, you underperfuse the kidneys. What happens when that occurs? Well, then your kidneys not getting enough oxygen and you have decreased kidney function, right? Cause kidney injury because of that. You're not filtering as well. So you got to watch. This can change from day to day, hour to hour sometimes, right? So watch out for renal dose adjustments for these drugs here. In terms of anti-pseudomonal carbapenems, remember, imipenem is pretty good, but you have to be careful in patients with really unstable renal function because you do, or not use it in patients who have seizure history because this can cause seizures. Meropenem is typically used more often because it does not carry that same risk. So most hospitals will have this on formulary over something like imipenem. Don't use ertapenem because it has pretty limited activity against Pseudomonas. Again, all of these require renal dose adjustment. And then piperacillin tazobactam is the only penicillin that's going to fit the bill here. We talked about that before, but again, renal dose adjustment. Why do I mention this so much? Because it's super important. You can really harm patients if you're not careful in dosing these things correctly, right? Moving on to the anti-pseudomonal fluoroquinolones. Typically, this is going to include things like ciprofloxacin and levofloxacin. They do provide additional benefits because they have good activity against atypical bacteria. So again, if you think back to that patient who had was working on an AC unit and they come in with a pneumonia now, you got to cover for Legionella. This is where something like a fluoroquinolone can be pretty useful here. And it has pretty good lung tissue penetration, which is beneficial. Due to some of the increasing risk for resistance, use this pretty judiciously. Make sure you're not using this for every single patient that comes in. Hold off if you don't have to, because again, there's side effects with it, drug interactions, things you want to watch out for. And these, again, do require renal dose adjustment. In terms of aminoglycosides, gentamicin, tobramycin, amikacin, again, these are all going to require therapeutic drug monitoring, because if you're not careful, you can cause oto and nephrotoxicity here. So do want to watch for that. Again, look at the patient's baseline kidney function and making sure you're adjusting based off the baseline, and then you can follow that up. You can monitor daily, BMPs and things like that to see what their kidney function is doing over time, look at the urine output, etc. And so again, we utilize the concentration-dependent killing effects of this drug by utilizing really big once-daily doses to get good lung penetration, because typically they're pretty poor on their own, but by giving really big doses, you get higher concentrations there at the lung tissue, which is beneficial. Okay. Then vancomycin, again, another one we're going to do therapeutic drug monitoring on. And so this one being a time-dependent killer, we can't get away with just one-time daily dosing. So you typically are giving this Q8 hours, Q6 hours, making sure you're staying above the MIC. And again, vanco doesn't really penetrate lungs super well, and so this is why we have to actually shoot for higher trough levels here. I'm not going to ask you specifically about trough levels, which ones are which, but just know because it doesn't penetrate the lungs well, we do have to go with higher dosing typically to target higher troughs. And again, oto and nephrotoxicity, but especially if you're using vanco with other nephrotoxins like aminoglycosides, that's where your risk really definitely goes up there, okay? Zyvox is good if you have patients who are poor candidates for vancomycin. However, it's expensive. We talked about interactions with antidepressant medications and things like that. The benefit here is there's no dose adjustment based on renal function, which is why some people want to go with that over vanco, because it's easier to do, and most people like to go with the path of least resistance. However, it's not very good from an antimicrobial stewardship standpoint. It's more expensive, and we like to hold off on this until we have a good reason to, because once patients become resistant, or bacteria become resistant to this, not a whole lot we have to go to, right? Okay, so that's for empiric therapy. So you should be able to figure out what empiric therapy should be for a patient who is at risk for multi-drug resistant pathogens. So, for instance, you have a little lady coming from the nursing home. She is, been living there for the past couple of years, comes in, lungs sound really junky, get the chest x-ray, it's very clearly pneumonia. What are you going to do for them, right? So what we're going to do is you're going to use, again, an anti-pseudomonal beta-lactam, so either piptazo, cefepime, or something like meropenem, one of those three, plus something else to cover for those gram negatives in Pseudomonas, so something like an aminoglycoside or levaquin, usually levaquin, or Cipro, fluoxetine, you can use either of those two, plus vancomycin, right? Vanco is going to cover all your gram positives and MRSA. So if I gave you an option on the test and I said, okay, well, go ahead and use piptazo, cefepime plus linezolid, not a good option, right? Because one, that's 2 beta-lactams together, which doesn't make sense. You don't get additional benefit from that. And then we don't use Ivox first choice, right? Vanco should be the first choice there. So be able to figure out like what are some good combinations you could use, because there's probably going to be a test question about that, okay? Anyway, so we scale back therapy once we have cultures back and know what the definitive organism is. If possible, we like to switch over to PO if we can, right? So streamline your therapy to fewer drugs. If the patient's receiving that empiric therapy and it comes back and it's MRSA, get rid of the gram-negative coverage. You don't need the beta-lactam. You don't need the fluoroquinolone. Just go with vancomycin, right, if that's appropriate. Again, if you can switch over to PO therapy, that's always going to be beneficial, because, again, if you can get that IV line out of the patient, that's also one less source for infection there. But things go wrong, things fail. So why could that be? Well, you could have wrong therapy. So you either have resistant pathogens, or maybe you didn't use appropriate empiric antibiotics. You could have the wrong diagnosis. Not everything is infectious, so it could be a PE or a cancer or something. And then think about complications too. So things like lung abscesses can occur. You could have C. difficile colitis that can develop after this, because you just wrecked the whole gut flora by giving them 3 broad spectrum antibiotics. So those are things you want to consider. Treatment duration depends on the pathogen in some cases. So usually a week or so is pretty good for most patients, but they have some of these more nasty sort of gram negatives like Pseudomonas or Acinetobacter, 10 to 14 days is more appropriate. Okay. So that's it for pneumonia. Let's move on. Let's see. Question here. Okay, let me see. This is actually a good point here, so I want to mention this. So someone said, for patients on hemodialysis, they would get vanc less frequent, or in less frequent intervals. Would this still be a good treatment option for them, or would the risk outweigh the benefits? This is a great question. So vanco, yes, you're absolutely right. You would use this less frequently in those patients. So as an example, actually, let me just go ahead and show this to you. So I think it's good to show you some real world application here. All right. So here's the lexicon page for vancomycin. And so I'm going to go down to the dosing and just make sure you guys can see that. Here we go. Renal impairment for adults. Here's how we're going to dose this, right? So this is the important table I can focus on here. So notice here, creatinine clearance, it gives you in terms of mLs per minute, excuse me. And then it has loading doses, which you can use to get to steady state a little faster, and then the maintenance dosing. So this is what I want you to focus on here. The dosing doesn't actually change. You're using roughly the same dose regardless. It's the interval is what actually changes. And this is the important point here. You don't want to change your dose because you got to get sufficient concentrations. It's just a matter of giving the body enough time to clear it out based on what the renal function is. So if they have really good renal function, then you're dosing it every 8 to 12 hours potentially, right? If you're getting a little bit worse kidney function, you do it every 12 hours or every 24. If you have, say, 15 to 50, which is pretty poor function. Even less than that, then you're dosing it much less frequently. So for some patients, you may do every 48 hours, every 72 hours. Frequently at that point, we do what we call random levels. So we'll give a dose, and then we'll check it maybe a day or two later and see where it's at. If it's still high, then we don't redose. Give it another day. Come back. If it's still high, don't do anything. Give it another day. Come back. And then finally, once you get around that trough goal level, once you get there, then you redose it. Okay? And so you can do that same thing with dialysis. Frequently, we would do things where we would actually have patients say if they get Monday, Wednesday, Friday dialysis, we would give them dialysis on Monday and then dose Vanco right afterwards. And so that would be basically good until they got dialysis on Wednesday. Dialysis would actually suck all that Vanco out, and then you could redose them afterwards. And so there's a lot of different ways to do it, but basically that's a really good point you made there. And yes, that you would give it less frequently. We still use Vanco all the time, even in dialysis patients, just because it's so effective and it's, we know how to dose it. We have a lot of experience with it. And so there's no reason why we can't do that. You just have to be more cautious with them, make sure you're watching it. So, good question. Okay. Let me switch back here to our PowerPoint. So let's talk about anaphylaxis treatment. And of course, you guys are always welcome to post comments or questions in the chats. Makes it a little bit more interactive. Maybe that will help my energy levels for these morning sessions here. Let's talk about anaphylaxis briefly here. So what is anaphylaxis? What's a severe systemic allergic reaction that really involves a lot of different organ systems? But I mention it here because obviously the airway is one of the most problematic things you can see with true blue anaphylaxis. But you can see that complete obstruction of the airway because everything gets so edematous and swollen, and it can lead to severe hypotension and cardiovascular collapse. It's pretty nasty when you see it come in. You have a true anaphylactic reaction, right? So what do we do for them? First thing I want you to do, you got to expand the volume, right? When I mention that, volume expansion, I'm not talking about how loudly you talk to the patient or something. I'm talking about blood volume. And so this is where we can go ahead and give them IV volume expansion with IV crystalloids. What do I mean by crystalloids? Not some sort of alien race. Crystalloids basically means any kind of salt containing solution, right? The most common one being 0.9% sodium chloride. This is a good number to remember because this is normal saline, right? Why is it normal? Because it's isotonic to the blood, essentially. Okay, it has roughly the same sodium content as our blood as well. So 0.9% is good to know because if you ever see like half normal saline, guess what? It's 0.45%. So it's handy to know that 0.9. Anyway, so if they're hypotensive, go ahead and give them some IV crystalloids typically here. And again, I like to include some dosing just so, because this is such a ubiquitous thing. This will cover you for all patients who need IV volume expansion. Typically for a dose, and I think I covered this last semester, so stop me if I'm just boring you with repeating it, but could bear repeating. Typically for an IV bolus of fluids, you're going to give them 20 mLs per kilo. For an adult, this roughly equates to 1 to 2 liters. So, and again, if your patient's not hypotensive, then you don't have to do this step necessarily, right? So if you have someone who had an allergy to peanuts and they accidentally got exposed to a peanut and they felt kind of itchy and they felt like their throat was closing up and they went ahead and used their EpiPen, which we'll talk about later, and they come in, their blood pressure is fine, you don't necessarily have to give them fluids, right? It's not a bad idea, but you don't have to do it. So take it into clinical consideration in terms of what's going on with the patient. For really severe cases where they're really profoundly hypotensive, you may need like 4 to 8 liters of fluid here because they're just leaking all this fluid out of their capillaries because they're so vasodilated, right? But to start with, 1 to 2 liters for adults. For kids, you do like 20 mLs per kilo. You could still use that calculation for adults too. It's totally fine. So just round to the closest liter. And then you'd want to give them maintenance fluids afterwards in order to keep them tanked up, right? And so again, this is where that 4-2-1 rule comes into place, like we talked about before, where again, for the first 10 kilos of their weight, you're going to do 4 mLs per kilo, right? So again, they weighed 10 kilograms and they're going to get 40 mLs an hour, roughly. For the second 10 kilograms, again, 2 mLs per kilo. And then for every subsequent kilograms after 20, they get 1 ml per kilo, right? So a 60 kilogram patient would get 40 mLs an hour for the first 10 kilograms of their weight, and then 20 mLs an hour for the second 10 kilograms, and then they still have 40 kilograms left over, so 40 mLs an hour for that because it's 1 ml per kilo. So they get a total amount of 100 mLs an hour. Okay, that doesn't make sense. Go ahead and let me know. I can go over that some more. So that's the first step. You have someone coming in. And again, if you have someone coming into the ER and they're truly anaphylactic, a lot of these things are happening in parallel. Typically, these are kind of like drop everything kind of patients. And so you have multiple people kind of helping out with these. The thing that's really going to save their life if they're truly having any kind of airway compromise, if they're getting hypotensive, anything like that, is going to be epinephrine. And again, epinephrine is an endogenous catecholamine, meaning it's something that we produce ourselves that can be released from the adrenal glands. It's going to be acting on both alpha and beta receptors. And what this does for us is a couple of things. From the alpha side, if the patient is vasodilating, they're hypotensive, this is going to activate these alpha 1 receptors and squeeze on those blood vessels, okay, get the pressure up. From the beta side, it's going to affect the beta 2 receptors in the lungs, which will be important when we talk about asthma in a little bit. That's going to dilate the bronchioles, right? So the bronchial smooth muscle will relax and will open that up so patients can now breathe again, okay? Also constricting on those vessels is going to cause swelling to go down as well. So we're going to see vasoconstriction, decreased permeability in the vasculature, and bronchial smooth muscle relaxation. All great. It also does help out with some of the angioedema, urticaria, etc. Okay. How do we give this? Typically, for most patients with anaphylaxis, they're going to get either IM or sub-Q doses. For very severe cases, we'll do IV. This is generally not going to be the case. People feel pretty miserable after getting an IV dose of epinephrine, so unless they're actively coding and dying on you, we don't need to do that. So IM dosing is totally reasonable there. And here's an example of an EpiPen, which is an auto-injector. Any patient can give this to themselves to get a nice IM dose of epinephrine there. And so most patients who have a history of anaphylaxis will carry these around with them. And so make sure you are careful with these because, again, there are different varieties. So, for instance, there's an EpiPen Junior, which is good for pediatric patients and is half the dose of this. So you don't want to actually give an adult patient an EpiPen Junior because that wouldn't be enough. Vice versa, you don't want to give an EpiPen to a kid because that would be too much for them, right? And even that, if you're dealing with in the hospital setting, there's different concentrations available. And you don't want to screw this up because if you give someone too much epi, that can lead to stroke. It can lead to MI, hypertension, a lot of problems there. You don't want to give them too little because it's not really going to work that well. So gotta be cautious here. And again, all these side effects make sense based off the mechanism of the drug. Just like you would get if you had your fight or flight response being activated, you get anxious and hypertensive and tachycardic and diaphoretic. All those totally make sense based off the mechanism. Is when you overdose and get too much of it, it's when you can see things like the cerebrovascular hemorrhage and MI and all of that. Okay. What else do you want to give these patients? Typically, you want to make sure that you are giving an H1 blocker. So we already talked about these back in the ENT section, but things like diphenhydramine, hydroxyzine are common ones you're going to use. Typically, we'll give these intravenously for more severe cases. If it's less severe, if they're just having some pruritus and rash, then we may just give them oral diphenhydramine. It just depends on the severity, because again, it's kind of on a sliding scale. Not everyone coming in is going to have airway swelling and hypotension, all of that. They can come in more mild for sure. But this really helps out a lot with the rash, pruritus, and hives, right? So all the cutaneous effects. Now, all this histamine being released also affects the GI tract and can affect stomach acid production. We haven't talked about this extensively, but we will when we get into GI towards the end of the semester here. But this is going to be basically useful to help block things like increased gastric acid secretion. Now, this is actually out of date. I've got to get rid of this because ranitidine was recently taken off the market for causing cancer. So I should have probably updated that. But instead, you probably use something like famotidine. This is the good one here. So you probably want to use that instead. I'll just bold that so you know which one is which. Basically, ranitidine got taken off the market like this year because of some risk for cancer, even though we've been using it for decades and decades. It was something we just now noticed, but we'll talk more about these extensively when we get to the GI section, so just kind of hang off on that. Not every patient needs to get an H2 blocker, but almost everyone will get an H1 blocker, so just FYI. Okay, in terms of bronchodilators, this will be handy. We'll talk more about this when we get into the asthma section coming up, but albuterol is typically your go-to beta-2 agonist and basically works to relax the bronchial smooth muscle. This doesn't take the place of epinephrine by any means, but it could be useful if they're just having like respiratory symptoms like wheezing, things like that can be beneficial. I'll talk more about the side effects of this in just a little bit. And then corticosteroids are very, very important. Typically what you're going to find with these patients here is that there's sort of like two phases of anaphylaxis where they'll have an initial phase where they can have the airway swelling and hypotension, all that will last for a couple of hours, but then there's a delayed phase that can show up hours later, and that sometimes, if you're not taking care of that, can be what kills the patient. And so this is where corticosteroids come into play here. They're basically blocking the production of inflammatory mediators at the site of the nucleus. So it's very powerful what it does, but because it's working at the nucleus, changing transcription factors and production of inflammatory cytokines, it's slower. So it takes hours to work in some cases. But it works on all aspects of anaphylaxis, which is fantastic. So just about everyone coming in for an allergic reaction will typically get an H1 blocker like diphenhydramine and corticosteroids. Not everyone has to get epi. If they're severe enough to get epi, then yeah, definitely get that on board. But almost everyone's going to H1 blocker and a corticosteroid. This could be prednisone, methylprednisolone, which we use a lot for IV therapy, dexamethasone. Any of these are reasonable. It's always funny because working in the ER, it's a pretty intense sort of environment, and a lot of the people working there are equally intense. And it's funny because a lot of times the providers and people working there don't know all the nitty gritty of how these drugs working. So, for instance, I'll have a patient coming in for anaphylaxis, and the nurse is like, "We got to get the steroids. Where are the steroids at? Get them ready." And it's like, "Well, I'm working on the epi right now. We need the steroids." Well, you do need the steroids, but it takes a while to work. So let me get the epi first, which is actively going to save this person's life, and then I'll worry about the corticosteroids. So, I think about the order of operations there a little bit, but they don't know. And it's a good education point to make to them. Like, hey, this takes a few hours to work. Getting it in an hour, 5 minutes later, probably not going to make a difference. However, the epi and the Benadryl, that may make a big difference in the immediate future. So that's it for management for anaphylaxis. So again, questions from this might be things like, which medications are most appropriate based on patient presentation. So if they come in and they're just having, wheezing and some rash with pruritus, they probably don't need epinephrine. But if they come in and they're hypotensive and their airway swelling and they have to be intubated, they definitely need epinephrine, right? But all of them are going to need corticosteroids, usually at least a 5-day course, if not longer. All of them are going to need Benadryl, an H1 blocker, things like that. So those are things I want you to kind of key in on in terms of like the patient situation, like what are they going to require there. So David's asking, do you often find yourself in conflict on those type of situations over treatment? Not necessarily conflict, I would say. Generally speaking, my role is to sort of facilitate proper like drug selection and then appropriate drug delivery to the patient. So I may offer up suggestions for maybe alternative therapy or things like that. Ultimately, the final say goes to the provider. But if I think something is like not safe, or I think that it's the incorrect choice, and I feel really strongly about that, yeah, it's within my right not to verify that order, not to push it through. It's a very rare case I have to do that. And it's not a situation you want to put yourself in typically. But you have conversations with the providers. You talk with them and see, okay, well, it's interesting. Did you think about this? Maybe this might be a better drug. Sometimes you get some wins, sometimes you don't. Just because someone does something different doesn't mean it's wrong. It just means maybe they have a different perspective. Maybe they have a different set of goals than you, right? So again, ultimately, everyone's there to take care of the patient. So as long as you go into all agreements with that in mind, no one's there to be malicious to your patient. At least they shouldn't be if they're working in healthcare. Then usually you can keep things pretty civil for the most part. So conflict, I wouldn't say, but certainly enlightened, invigorated discussions. How about that? That's a better way to state it, maybe. Anyway, so switching gears here and going into asthma. So what is asthma? And this is actually something near and dear to me because I actually suffer from asthma. So what is this? This is a good continuation from talks of anaphylaxis because a lot of it's the same sort of pathway here in terms of having an allergic response. IgE is mediating these responses here, and overall what you're seeing is a inflammation and a swelling, or at least a narrowing of the bronchial airways. Okay, and so you're going to find this means these patients also have increased bronchial responsiveness. Like you've ever seen an asthmatic patient coming in for an acute exacerbation, you know what it looks like. They're short of breath, they have complaint of chest tightness, they're wheezing, although not everyone wheezes, but a lot of people do, coughing, things like that, right? And of course, a lot of genetic factors, but certainly environmental factors play a huge role here. So, like if I go around a new animal for the first time, like a dog or a cat, chances are it's going to trigger my asthma unless I have appropriate therapy on board, which I'll talk about in a moment here. So we've talked about the arachidonic acid pathway before, and again, remember that we talked about it in terms of inflammation and causing fever and things like that. We talked about the NSAIDs and aspirin affecting the cyclooxygenase pathway here because it blocks that enzyme, thus you can't produce thromboxane and prostaglandins, etc. There's another side of this pathway though, and there's it's called the leukotriene pathway. And so instead of cyclooxygenase affecting arachidonic acid, it undergoes enzymatic reaction with 5-lipoxygenase. This is the enzyme, so it's kind of the counterpart to cyclooxygenase. 5-lipoxygenase eventually forms what we call the leukotrienes. There's a bunch of different varieties here, but I'll mainly focus on LTD4 and E4. So these are the big ones you're going to see here in terms of asthma, in terms of causing that bronchial hypersensitivity and narrowing that occurs there, that increased responsiveness and bronchoconstriction that occurs during an asthmatic attack, right? But anyway, so some sort of allergen comes by, patients react to that through IgE production there, and that causes mast cells to degranulate. This is very similar to other allergic reactions we talked about in the eyes and the nose. The same pathway here, right? It just happens to be the asthmatic patients are more likely to have this from a bronchial standpoint here. And so when they have exposure to the allergens, they're going to have all this histamine being released, leukotrienes, and all of this. And so a lot of the drugs we're going to focus on are going to be able to maybe perhaps block the effects of these medications, or maybe even block production of them in the first place. Certainly other things can cause asthma exacerbations. So it can be things like viral infections can do this. Exercise can do this for some patients. Just depends on what their particular triggers happen to be here. And actually, an interesting thing we do sometimes, especially in asthma research, maybe not necessarily in clinical practice, because usually you can make a diagnosis for asthma without having to do any kind of provocative testing. Usually the history is enough to tell you what they have and just a quick physical. But in some cases, like in research, we have to make a more definitive diagnosis. We can actually induce an asthma attack with something called methacholine. So this is actually important here for some of our drugs we'll talk about. Is that another big influencer on things like mucus production in the airways, things like bronchoconstriction, is acetylcholine. Acetylcholine affecting the muscarinic receptors on the lungs can cause them to constrict. And so that's going to be one means of treatment that we'll look at later on. Is actually blocking that effect. So we can actually induce an asthma attack by using something called methacholine, which is similar to acetylcholine. And then once we see that they have that increased responsiveness, or they have a change in their FEV1, then we have a pretty good idea they have a diagnosis, and then we can then reverse that with some other agents here we'll talk about in a little bit. So we do that a lot in research. Oops. All right, so our main goals here are to reverse bronchospasm. So we'll see the drugs we use here, things like beta-2 agonists, ipratropium, and then a lesser used drug called theophylline, which we'll talk about later. You could remove the trigger or antigen, so things like cromolyn and etacromol. These should look familiar to you since we covered these in ENT, I believe. And then control the inflammation, steroids and lipoxygenase inhibitors. So we'll get into where we're using these specifically. Keep in mind, I will probably ask questions about this, but you need to keep in mind which drugs are good for quick acting relief of bronchospasm and which drugs are good for control of preventing bronchospasm from occurring. Okay, and students always get this wrong on the test, even though I still stress this every time. Some people figure it out, some people don't. Know which drugs when I'm talking about them are good for quick relief and which ones are for long-term prevention of symptoms. We'll do the same thing with the cardio when we talk about, for instance, when we talk about angina, when we talk about seizures. This kind of mantra will come up over and over again. So you got to think about what's good for quick acting treatment of something, and what are things to help prevent those things from occurring in the long term. Okay, obviously an ounce of prevention is worth a pound of cure, and that is the same here, even talking about asthma. And so, again, I'm not going to get into the diagnosis specifically, but obviously this is how we can determine if it's more intermittent, meaning it happens sort of randomly, or perhaps with specific triggers, fairly mild versus your more persistent cases where symptoms become more frequent and more disruptive to the patient. Certainly your pulmonary function test will be beneficial in helping you to make a good diagnosis as well. I'm not going to ask you to tell me, is the patient moderate persistent, severe persistent? I don't really care about that so much because you get that in other classes. But we will focus on the drug therapy, obviously, because this is your pharm class. So what are we going to do? Basically, we're going to reduce that level of bronchial responsiveness in the long term so we can reduce inflammation. And that's going to be helpful. This is where corticosteroids are going to come into play here. So we're going to have inhaled corticosteroids. We'll talk about how those are going to be beneficial for preventing bronchoconstriction and decreasing inflammation for the long term, right? So prevention of symptoms from occurring there. Because I'd much rather have prevent an asthma attack than actually have to treat one, because again, asthma attacks don't feel very good. So then also to prevent or reverse acute bronchospasm, this is where we can talk about things like allergen avoidance and also treating it with short-term beta-2 agonists. And so I'll get into the details of what those are in just a moment here. So this is the list, typically looking at here of a quick relief versus long-term control or medication. So quick relief includes our short-acting beta-2 agonists, anticholinergics, and then systemic corticosteroids. So if someone is coming into a healthcare environment with an asthma exacerbation severe enough they had to come to the ER, for instance, we're going to give them systemic corticosteroids, meaning either oral or IV steroids for a short course, usually like 5 days or so. That's for quicker relief, even though I told you corticosteroids are relatively slow. This is like on the order of hours. Versus on our long-term controller medications, we're going to see we have long-acting beta-2 agonists. Note here the differentiation. We don't use long-acting ones for quick relief. We have our inhaled corticosteroids, which we're going to see these actually have a much more delayed onset of action than your systemic ones. We have leukotriene modifiers, mast cell stabilizers, anti-IgE antibodies, and then methylxanthines, theophylline. And in fact, some of you might actually be on a methylxanthine right now and not even know it, which I'll talk about in just a little bit. So let's get into our beta-2 agonists. What do these drugs do? Well, basically, they activate beta-2 receptors on the lungs, and they're going to cause an increase in cyclic AMP, which leads to relaxation of that smooth muscle, right? So typically, beta-2 agonism leads to smooth muscle relaxation, both on the blood vessels, but more importantly here, on the lungs. And also, we're mainly going to be focusing on asthma with inhaled therapy, because that's going to get the drug right to where it's needed, and it typically is going to limit the systemic side effects patients are going to experience. Not always, but they can help. So what we're going to see here. So these are quick acting medications. We have quick acting and long acting varieties. So quick acting typically works within several minutes and can last up to 4 to 6 hours. The long acting variety are typically for prevention of symptoms, and that can last 12, maybe up to 24 hours, depending on the case there. The main side effects you're going to run into with these inhaled forms are going to be increased heart rate, because again, they don't just affect beta-2, there's a little bit of beta-1 activity, so they can increase heart rate there, and then cause tremor. Tremor typically being from activation of beta-2 receptors on the skeletal muscle can increase some hyperactivity, and you can see tremor associated with that. So short-acting varieties, we have albuterol, which is kind of like your go-to asthma medication for quick relief. I'm sure most people have heard of albuterol before. There's a variety of brand names like ProAir, Ventolin, etc. There's also another one called levoalbuterol, which this is just the left-handed version of albuterol. So albuterol itself is a racemic mixture. Levoalbuterol is the left-handed form there. So for instance, if you got 5 milligrams of albuterol, a equivalent dose of levoalbuterol would be like 2.5 milligrams. This is way more expensive, but some people feel like it gives them less side effects associated with it. I don't personally believe that in a lot of cases. You can just use a lower dose of albuterol and they'll be fine. So frequently providers will say, well, let's get some Xopenex for this patient. I say, you sure about that? Because it's real expensive. Can be several times more expensive than albuterol. And we just give a lower dose. Just use a little bit less and it'll be fine. So there's that. So for long acting, these are going to be drugs we don't use alone for asthma. I'll talk about how we use them in combination with corticosteroids, but you may see these by themselves for COPD, definitely not for asthma, because it can, there's actually been some cases where it's led to increased mortality, so you definitely want to avoid that. Excuse me. So as I mentioned, in terms of side effects from reversing that bronchospasm and by activating beta-2 receptors, we're going to see here that you get the tachycardia. Rarely do you get hypotension. You get some dizziness and tremors and hyperglycemia. A lot of that's related to just the beta-2 activation kind of body-wide. How much of these systemic effects you get depends on how the dose is administered, how big of a dose they get. If I have a little metered dose inhaler, an MDI, I'm just getting a quick spritz there, I'm much less likely to see systemic side effects versus if I were to take something like a nebulizer and inhale a huge amount of the drug, okay? We'll talk about some different dosage forms in a little bit here, but the dose really matters here in terms of systemic side effects. I've had some patients actually take oral albuterol, and that's horrible for side effects because, again, you're absorbing all that systemically and affects everything. So it really just depends on how big of a dose they're getting there. I'll kind of elaborate on that in just a little bit. You can actually also see hypokalemia. It's kind of interesting because activating beta-2 receptors actually causes increased uptake of potassium into the cells, and so you can actually use that as a treatment for hyperkalemia, which is kind of interesting. So something to note there. Next up, we have our inhaled corticosteroids, just to make sure I talked about. So again, formoterol and salmeterol is how you would say those two long-acting beta-2 agonists. Okay, so next we have the inhaled corticosteroids. This list should look pretty familiar to you if you recall what we talked about with the nasal corticosteroids. And again, the benefit here is they're working right where we want them to, in the lungs, right? So it avoids a lot of systemic side effects of steroids like hyperglycemia and things like that. No immunosuppression here that happens systemically, at least. We have things like beclomethasone, budesonide, flunisolide, fluticasone, mometasone, and triamcinolone. And if you notice here, you can see that I put some of the nasal varieties along with the pulmonary varieties, and you can see how these could be potentially mixed up here. However, usually they at least name the brand name so it's a little more obvious. But these mix-ups happen all the time in medicine. So you'll have someone who does the medication reconciliation incorrectly, and they'll put down the nasal form of fluticasone versus the inhaled form, and it's very easy for that mistake to occur there. And the names look really similar. Patients might mix them up themselves. So just one thing to note with that. Now, again, these are working to inhibit the anti-inflammatory cascade by preventing production of these inflammatory cytokines. But the note here is that it takes up to 8 weeks for maximal effect. So patients have to take this consistently and chronically in order to get the benefits. It's not going to fix, how many exacerbations they're having overnight. It takes weeks for this to occur. Okay. We'll see there's actually some combination products here in just a little bit that can actually help speed this process up a little bit. I'll talk about that in a moment here. So the anti-inflammatory actions which you're going to see in terms of adverse effects, though, you can see some local immunosuppression. So what happens when you inhale drugs into the respiratory tract? Does every single particle of that drug go right down into the lungs? That'd be nice, but it doesn't occur, right? Because things like the back of the throat get in the way. You're going to swallow some of that medication. So what happens is a drug that hits the back of the throat can cause a local immunosuppression, and that can lead to thrush, so oral candidiasis. So if you see someone with thrush, usually they have some degree of immunosuppression. So frequently that's things like HIV. Not always. It could just be they're asthmatic and they take an inhaled corticosteroid that causes this. So this is why it's super important. This is the best education point for the inhaled corticosteroids. You got to swish with water. You swish and swallow, swish and spit, whatever. Make sure they wash their mouth out after taking these. Okay, big education point. High dose use may lead to some growth suppression in children, although it's rare that we can say that is a definitive cause there in some cases. And then again, we're about inhibiting the immune system. This is rarely a systemic problem, though. It's really just that local effect we see there in the back of the throat. Now, we do see some combinations, and so you may see, for instance, combinations of formoterol plus budesonide, which is a mixture of a long-acting beta-2 agonist plus the steroid. The benefit here is that the beta-2 agonist works right away, so it's already working, 12 hours at a time. So usually these are dosed like twice daily, but it'll be working throughout the day. So you get the benefit of a beta-2 agonist right away, while the effects of the corticosteroids take time to work. Now, the problem is that patients will feel better, and they say, well, I'm not having any asthma attacks anymore, so let me go ahead and stop taking it. They stop taking it, and then guess what? Asthma attacks start to come back. So, again, consistency is the name of the game here. Make sure they're taking these things. Even if they feel great, the reason why they feel great is because the drugs are working. So make sure they're sticking with that. So those are like the go-to meds for most management of asthma, right? So for long-term management of asthma and prevention of symptoms, inhaled corticosteroids are number one. If you want to use a combination, use inhaled corticosteroids plus long-acting beta-2 agonist, okay? For quick relief, short-acting beta-2 agonist is your main play there, right? So albuterol most often. Maybe levobuterol, but mostly albuterol. Now, here's some other controller medications we can look at that could be beneficial if patients maybe are bad candidates for corticosteroids, or maybe just using this in addition to get some additional control. It just depends. We next have the leukotriene modifiers. Zafirlukast, you're not really going to see very much. There's some problems with it, so I'm just going to mark that in red, so I don't want you to focus on that one too much, but definitely Singulair. This one you're going to see much more frequently here. And basically what these are going to do is block the LTD4 receptors, right? So they'll block those receptors, and that helps to decrease a lot of that inflammation, bronchial constriction, and things like that. These are not going to be good for quick relief. They're only for long-term control here. And the reason why we don't like Zafirlukast, which I would not recommend for any patient, is because it inhibits CYP2C9 and 3A4, whereas Montelukast does not. So really, you're hard-pressed to ever find a patient who's actually taking Zafirlukast. I don't know of any, but Montelukast I see all the time. So again, from the side effect profile, there's a lot of things listed here, but honestly, it's very benign. And in fact, in terms of like efficacy, it's going to be a step or two down from the corticosteroids. So, but it's pretty mild. So some patients, that's all they need. This can be especially helpful. You'll see frequently that they'll say take things like Montelukast at nighttime, because there's a thought that patients will produce more leukotrienes at nighttime. That's why you see a lot of nighttime awakenings due to asthma, and so that's one reason why you may see that dosing like that. So I definitely recommend that at nighttime, because you're likely to get a little more benefit out of the leukotriene modifiers. Okay. So up next, then we have for patients who are really difficult to control, who have frequent exacerbations, maybe frequent hospitalizations. Next, we have something called omalizumab. omalizumab or Xolair. This is, again, you can already tell something based off the name here. It's a monoclonal antibody. Probably mentioned a few of these already. These are going to be drugs that are basically designed, engineered antibodies. And these are actually designed to bind to IgE and neutralize it. So the IgE that would normally cause these reactions, that would cause bronchial constriction, this will then bind that IgE up and prevent it from doing its thing. So basically, you have patients who are having really difficult to control asthma attacks, frequently being admitted to the hospital multiple times. You need to, they can sometimes use this, but there are some downsides, as we'll see here. Dave's saying, with drugs like montelukast, do you find it helps with patients exhibiting atopic triad or multiple symptoms? You could probably ask someone that works more in pulmonology or an allergist if they see some additional benefit there. It can help with some of that, but it's only indications are mainly going to be for asthma specifically. But let me just take a double check here. I just want to, maybe for my own edification here. So I'm pulling up the thing here from montelukast, so you can see in terms of dosing. So for allergic rhinitis, so you can get some benefit from that. Chronic urticaria, so some of these things you'll see are off-label uses, which doesn't mean you can't use it for that. It just means that it does not have an FDA indication for that. Usually the drug companies will have to go to the FDA and will say, I would like to get indications for this particular cause. So for instance here, you'll see asthma and allergic rhinitis. Those are indicated uses. They have indications for that. However, if there is evidence to back you up and evidence for use for some of these things, you can use things off label, but you always want to have something backing you up. You never want something to go bad and a lawyer comes up and say, well, why'd you do this? And you say, well, I just felt like it. Not usually a good reason. So for a lot of off-label uses, it's good if you can have primary sources that back you up. So this is why they list out some of these different articles here that show that, yeah, you can use it for this, get some benefit. So you can see it just doesn't affect asthma. It can affect other inflammation and allergy as well. So potentially you can find patients on it for that reason there. So good question. Let me go back. So anyway, so we got Xolair here. So again, because it's a monoclonal antibody, it's a protein, which means it has to be injected. So it's an injectable drug. Also carries some problems with, one, they have to get it in the office, so they have to actually come in every 2 to 4 weeks to receive this. They don't give it themselves most frequently. Also, there is risk for anaphylaxis, right? You're like, well, I'm giving it for allergies. Why would it cause anaphylaxis? Well, because it's a monoclonal antibody. You're injecting foreign protein into the patient, and they can have a reaction to that. They can produce IgE against the Xolair. So some risk with that. The other thing, too, there's some risk for secondary malignancies. It's also very expensive. So because of this, we reserve this for patients who have really difficult to control asthma. It's really the big thing there. Again, you can see here the risk, while low, are definitely higher than what you're going to see with other therapies. So, but things that you definitely want to know about. Things you want to keep in mind, educate patients about. Okay, next we have our anticholinergics. You had talked about how acetylcholine acting on the bronchial smooth muscle can cause constriction. So if we block that, we can then hopefully get some smooth muscle relaxation there. And so this is used as an adjunct to beta-2 agonists. You're not going to see anyone for asthma taking ipratropium by itself. This can be useful as an add-on, okay? You may see this for COPD patients when using a long-acting form, but I'll talk about that a little bit later on, okay? So anyways, they're blocking acetylcholine at the muscarinic receptors in the lungs to prevent bronchial constriction, right? And again, these are inhaled drugs here. So first off, we have short-acting ipratropium. This is most commonly seen in conjunction with albuterol for like an acute asthma exacerbation. So if you ever hear of a duoneb, and again, a lot of times drugs just get called by their brand names, or they'll you don't hear a lot of people say, okay, let's give the patient ipratropium. They'll say, we'll give them Atrovent or give them a duoneb. A duoneb is a combination of albuterol plus ipratropium, so two together. Usually most hospitals don't carry the actual branded kind that has the combo together. It's just mainly the respiratory tech respiratory therapist who is giving the albuterol and the ipratropium. They're just mixing them in the same nebulizer cup and administering it that way. For long-acting forms, there's tiotropium or Spiriva. This is only used for COPD patients, so this is not used for asthma, but can again provide some more long-acting anticholinergic actions there. So, side effects, right? So you won't see these as often, mainly due to the fact that these are inhaled drugs, so they don't get a lot of systemic side effects. But this is a good mnemonic to help you remember the anticholinergic side effects. I'm not sure if I've gone over this with you or not, but it's really handy here. So, for instance, you can be blind as a bat, meaning you get mydriasis and blurry vision. You can see this more with your antihistamines, typically your first generation antihistamines. You can have CNS changes, sleepiness, things like that. Mad as a hatter, red as a beet, so you get flushing. Hot as Hades or hot as a match, whatever you like, for fever, hyperthermia, dry as a bone, so things tend to get dried out. This is actually good from an asthmatic standpoint because part of that allergic response is they produce more mucus, and that can affect aeration. So if you can try to dry them out a little bit, that can improve some of the airway blockage that's happening there. So that can be beneficial. And then bowel and bladder increase their tone, so you have constipation, urinary retention, and the heart runs alone, meaning you can see some tachycardia associated with that. Less likely to see it with inhaled varieties, but definitely with like your first generation antihistamines, you're gonna run into that pretty commonly. Okay. So if you had someone who was having a severe exacerbation, they're coming in, their at-home albuterol really wasn't working. This is where your oral systemic corticosteroids can be utilized. So this is not going to be for chronic use for patients because again, the systemic side effects pretty significant, right? And we don't want to do that to your typical asthmatic patient here, but they help to suppress, control, and reverse that airway inflammation here, just like it does for any other inflammatory condition we've talked about here. But again, most potent, but limited due to side effects of a systemic nature. So only used for those exacerbations are actually coming into the healthcare environment to receive extra help. This is where things like prednisone or prednisolone can be utilized here. Methylprednisolone is typically the kind of our go-to parenteral agent, or we have like dexamethasone. Any of these are totally fine. They're all going to have very similar side effect profiles. It's more often just a dosing difference. You know, how potent the drug is or how long the half-life is what changes here. But again, with short course use, like 5 days worth of therapy, you're not really worried about things like adrenal suppression or growth suppression. It's more so with like longer term use here. We have some patients that come in with such severe asthma exacerbations, they may be on 2 weeks of corticosteroids, in which case you do have to taper them down. And so you'll see those orders built into where they'll actually, if they're getting methylprednisolone, every 6 hours, they may change it to every 8 hours for 2 days, and then they'll go to every 12 hours for 2 days, and every 24 hours for 2 days, and then off, for instance, right? So there are ways you can do that that tapering such that you don't have to worry about adrenal suppression and putting the patient into adrenal insufficiency there. But of course, you can see worsening hypertension because it will hold on to fluids, which can increase blood volume and pressure, and issues like muscle weakness. This is more of chronic use there, and then immunosuppression. Again, why is that patient having an asthma exacerbation? Is it because of a viral or bacterial illness? Perhaps, and so this may not be the best thing for them depending on the situation. So typically, this is kind of the stepwise approach you're going to do for most patients. So if they have like really intermittent, maybe it's exercise induced only or certain triggers for them, just use a short acting beta agonist. That's that SABA there. Just use as needed. That's all they need. For persistent symptoms, this is where we're going to start off with like a low dose inhaled corticosteroid. I didn't even mention things like the mast cell stabilizers like cromolyn because we don't even use them very frequently. But as an alternative, they didn't want to use steroids, and you can use something like a long leukotriene receptor antagonist, or there's theophylline, which I'm going to talk about a little bit later on. But you should not be using theophylline for really any asthmatic patient unless they're pretty severe. I'll talk about theophylline later, though. So there's that. If you then need to step it up, right? Well, then use a inhaled corticosteroid plus a long-acting beta agonist. That's where you get, budesonide plus Moderol, for instance, or fluticasone plus salmeterol. Okay. Or you can bump up the dose of the inhaled corticosteroid. So sort of look at where the patient's at and then kind of step up therapy based on either adding a new drug or increasing the dose of what they're already on, right? So if I have a patient who I said was coming in and they were on a low dose inhaled corticosteroid plus a short acting beta agonist, but they're still having nighttime symptoms, what would you put them on? You could say a leukotriene receptor antagonist. You could say inhaled corticosteroid plus a long acting beta agonist. You have options there. So kind of think about it from a stepwise approach, what you would want to do if their symptoms are not being managed appropriately. Okay. All right. So there's a couple of different ways we can do this. So I mentioned the metered dose inhalers. Those are going to be the typical inhalers that will basically, they have a propellant mixed in with them that will, as you press the canister down, they will then release the drug at in a pretty forceful spray that the patient can then inhale. I'll talk about some means of technique here in just a little bit. There's some additional things that can help us out with that. So there's things like spacers and valve holding chambers. The problem with meter dose inhalers is that it requires a lot of dexterity and coordination to use, which sounds simple when you look at someone using an inhaler, but to do it effectively, it can be more challenging than it looks. Mainly because if patients are not inhaling fast enough, all the drug will just stay in the mouth basically, and they'll swallow it. Too fast, you can run into some issues as well. You need to kind of get right there in the middle, and so the benefit of using something like a valve holding chamber or spacer is it allows you to depress the canister. The drug will fill up the spacer basically. Again, if it doesn't make sense, I don't know if I have a picture. Let me show you. Go back to do my wonderful art here. Don't save. Okay, so imagine you have your inhaler. Boy, I hope this comes up one day when my eval say your art is just fantastic. So normally what would happen is when you press down this canister here, you get the spray coming out, and then the patient should inhale that. But again, if they can't coordinate pressing that down with the inhaling, then again, it's either going to end up at the back of the throat and they swallow it, or definitely not in the lungs where you want it to go. So instead, what you can do is have this valve holding chamber which attaches onto the end, and basically will hold the drug here. There's a little mouthpiece here the patient can breathe in. So you can depress the canister down. It will hold all the drug here in the chamber. And then when the patient's ready, they can then inhale that. So usually this is like a few seconds, right? The spacing this out. And it'll also, which is kind of neat, is a lot of these will make noises if you're inhaling too quickly. So it'll kind of like a whistle type noise. So it allows them to kind of breathe in on their own time, breathe it in and get it down to the lungs, okay? So that's what a spacer or valve holding chamber will basically do in those cases there. Again, there's other ways you can do it. There's things like nebulizers, which basically a tiny cup filled with the liquid drug will kind of vibrate at very high frequencies and allow the drug to aerosolize, and you can breathe that in. Useful for patients who cannot use something like a meter dose inhaler, or if they're uncooperative, so especially like kids, you put a mask on them and they can just breathe that in sort of passively instead of having to coordinate here. So in terms of technique, inhalers have to be shaken up because the propellant plus the drug can separate out a little bit. So you shake them up to mix nicely. And then some have to be primed, meaning the first time you use it, they'll tell you to do like 2 or 3 sprays through to make sure the first time you use it, it's actual drug all the way. And you'll have the patient breathe all the way out, okay? So have them breathe all the way out and hold the inhaler as seen here. I probably wouldn't tell them to keep it out of their mouth just because you can have a lot of drug being released into the atmosphere, but usually in the mouth, put their mouth over the end there. And then they'll basically have them start to breathe in, and as they are breathing in, press down the chamber, okay? And then they will then allow for sort of an airflow to already be kind of coming into the lungs, and that will facilitate the drug going into the lungs, right, where you want it to work. Then I have them hold their breath about 10 seconds or so, if they can do that. Have them count to 10. Some patients may not be able to do that depending on a lot of factors, right? But 10 seconds is the goal. And so typically you're going to see for like dosing for like albuterol or something, like, do 2 puffs, Q6 hours is needed for cough or wheeze, right? The thing with that is I usually have them separate out at least like 15-30 seconds in between puffs. If they can do it a few minutes, that's also helpful, because the benefit of that is they get the first dose in, that starts to loosen up some of that bronchosmooth muscle, allows the drug to work, and then by the time they get the next dose, if they wait a minute or two, that will allow the next dose to get even deeper and to affect even more of that bronchosmooth muscle. So it works better, and I usually tell them, you get more bang for your buck by waiting just a little bit longer. Allows the drug to work a little bit better there, okay? Okay, so again, asthma is a chronic disease, but understand what the long-term controller medications are versus what the short-acting meds are, and be able to identify those, especially for testing purposes, right? Or if you see a patient's med list on rotation, be able to identify kind of what is being used for what, okay? Obviously, they can avoid triggers. That's always going to be beneficial. And remember, it's a stepwise approach. So if they're on, an inhaled corticosteroid plus a long-acting beta agonist plus a leukotriene receptor antagonist, like what do you go to next? Well, something like Xolair might be a good option at that point, right? So kind of think on a step-by-step approach. All right, next up we have COPD. This will be pretty quick because there's not a whole lot of new drugs here. But again, this is a chronic condition for these patients. They're causing chronic lung damage over time, which is basically leading to destruction of the airways. You're seeing increased risk for infection. You're seeing all kinds of issues here. And so what you're going to find is that as lung function starts to depress over time, usually due to smoking and things like that, you'll find that the lungs have a pretty good capacity for reserve capacity for a while. So patients will be asymptomatic for quite some time before they start to develop symptoms. And then, by then you've already lost, a decent amount of lung tissue at that point, or effective lung tissue for oxygen exchange. And so obviously if we can try to hold that off and we can try to prevent as much damage as possible, that's always going to be beneficial here. But I just want to kind of show you the stepwise approach here that we would go for these patients. So early on, obviously you want to be regularly assessing lung function. You want to stop smoking if at all possible there, and then you want to consider getting the pneumococcal vaccine where appropriate age, and then also the annual influenza. The benefit here is that patients who have COPD typically are going to be more at risk for pulmonary infections, and so by doing this you can at least get rid of two of the more common ones, or at least mitigate your risk, right? So as they become more symptomatic, this is where things like short-acting beta agonists can be useful here. They can also benefit from long-acting bronchodilators. So this could either be something like a tiotropium, which is a long-acting anticholinergic, or something like salmeterol, formoterol, things like that. And then you're going to see combination therapy can also be used, like anticholinergic plus a beta agonist bronchodilator. So if I mentioned Duaneb, that's ipratropium plus something like albuterol together in that case there. There's another drug called theophylline, which I think I talk about theophylline. Actually, I don't. We don't use it too frequently anymore, so I probably didn't mention it just because I had too much material already cover in limited time as it is. But theophylline is something you use very last line. Very rarely will you see being used because it's a very narrow therapeutic index. It's pretty nasty from a side effect profile. But again, you're stepping up your therapy as you go along, combining inhaled steroids, long-acting beta agonists, long-acting anticholinergics, just kind of see what the patient's not on, and then try to either maximize the dose that they're taking or add on something else. So it's not uncommon these patients are on 2 or 3 meds just from the COPD standpoint. And then, things like surgery might be necessary at some point. They might need to go on oxygen, all of that. But the medication can be beneficial in the meantime. Okay, so as I mentioned with smoking, it's a major contributor to COPD. If you can get them to stop, that would be fantastic, but that's a difficult thing to do for a lot of patients because they develop a psychological and a physical dependence on the drug. However, we do know the damages that it does, and it'll be interesting to see the long-term effects of the increase in vaping and things like that. It'll be interesting to see all the additives and things like propylene glycol and things like that are mixed in to see what happens there. So I'll be curious to know in years to come. There's a few different agents we have here used for smoking. Most of them either rely on replacement of nicotine, or they may be trying to decrease symptoms of nicotine withdrawal via some other pathways here. And so that's the main thing you want to do when patients are trying to come off of an addiction like this, is to mitigate their withdrawal symptoms. Because if they feel withdrawal symptoms, they feel miserable because they don't have access to their nicotine, that's going to increase their risk for going right back to it. And so that's what we're trying to do with this. First off, I want to talk about bupropion. This is actually an antidepressant drug. This is what it's used as most frequently. However, in terms of it being used as an or as a smoking cessation aid, you may see it called Zyban as the brand name for it there. Basically, you can see that the reason why people get addicted to a lot of substances like cocaine or heroin or nicotine is because it activates this reward pathway in the brain. Basically activates this mesocortical pathway. And so just like when you have a big juicy hamburger, if that's what you like, or if you have sex, or if you have anything like that that activates that dopamine pathway, your body says, wow, that was really great. I would like to have more of that. And in cases for people who are predisposed to addiction, they say, I'd like a whole lot of that all the time. And so it becomes difficult because if you shut down that dopamine pathway, they feel miserable because, not only do they have physical symptoms of withdrawal, but also they feel kind of miserable because that reward pathway is not being activated. So what we can do here is actually use a drug called bupropion, which helps to re-establish normal functioning of that dopamine. Basically, what it does is it helps to re-establish normal functioning of dopamine in that pathway. So it doesn't necessarily replace what the nicotine was doing. It just helps to kind of re-equilibrate things a little bit and try to decrease the smoking, the urge to smoke, right? And so that's what we're going to be using this for. And if they have concomitant depression, that's beneficial too, because they can kind of get double duty out of this. So you can see that how it's used here. Again, I'm not going to ask you dosing on the test. And I apologize, I'm going to go a few minutes over if you don't mind, just so I can finish up this section for your quiz, which I think is next week. Avoid this in patients with seizure disorders because that is a risk with this drug here. And don't use it with any other drugs that potentiate the effects of serotonin and dopamine and things like that. So any other depression drugs, you don't want them to be on bupropion plus an antidepressant because you increase your risk for things like serotonin toxicity and other types of toxicity here. So just basically avoid this with other antidepressants. As I mentioned, you have nicotine replacement agents. These are basically used to replace what the patient was basically missing by not smoking anymore. And so this is helpful for those sort of physical withdrawal sort of symptoms there. And it just depends on what dosage form works for your patient, whether it's a gum they're using, the patches. Some of them will use like an inhaler. And in fact, like vaping has been useful for some patients to help them stop smoking because it's replacing what the cigarettes have, right? The nicotine they're not getting there. And so make sure that patients don't smoke with use of these, right? Because it's going to be way too much nicotine. They can get side effects like tachycardia, arrhythmias, seizures potentially, hypertension. So you got to be careful. Don't mix and match nicotine replacements with more nicotine, okay? Now bupropion, that has no nicotine in it, so you could use that in addition to, and that's totally fine. If they fall off the wagon, that's reasonable, but don't have them use both of these together. Okay? The last drug we'll talk about here is called varenicline or Chantix. This one's kind of the newest of the bunch. It's kind of interesting because it's a partial nicotine receptor agonist. So it doesn't activate it as much as nicotine does, but just kind of tickles the receptor and helps to mitigate a lot of those withdrawal symptoms, which is beneficial. And so actually what the patient will do is they'll start taking varenicline 1 week before their quit date. So basically, you'll have varenicline will come in, it will kick some of that nicotine off the receptors, and will start to occupy that. And then when the patient's ready, about a week later, they'll go ahead and stop smoking. And then they're left over that Chantix in the system that will then help them stave off those withdrawal symptoms. Take it for about 12 weeks or so, and then see how they do, see if they relapse or not. So the side effects are pretty wild for this one, though. You do want to be careful in patients with depression or any history of like suicide, because this can worsen that. And actually, one of the biggest side effects you're going to see with this is intense dreams. One of the big things you'll see, we'll talk about it. I had a cousin one time that took Chantix. He's actually he used snuff all the time. So he actually used oral tobacco products. He said, "Man, I took that Chantix and that stuff. I had some wild dreams, man." And I said, "Well, what kind of dreams?" I don't even know, but they were wild. That's all he said. Not enough to stop taking it, but it was pretty strange for him. And so you'll see this a lot with patients. But be careful if they have depression because it can worsen that. Last bit here is make sure patients are up to date on their vaccinations, mainly pneumococcal and annual flu. I also suggest if you have not received your annual flu yet, it is available. Go get that taken care of unless you have a good reason not to for any particular reason. I would recommend it. Anyway, so that's it for this section. We'll see if you guys have any questions. I don't see anything. Oh, I have a few questions here. Let's see. I'm going to switch over. So looking at this, someone said, will the quiz be mostly matching it? There'll be some matching. It'll be similar to the last quiz there, where it'll be some matching. It'll be some multiple choice because I want to get you prepared for the test itself, all of that. So yes, there'll be some matching on there. Is epinephrine renally dosed? It is not renally dosed. You're more dosing it to effect. For something like anaphylaxis, you're typically giving like a one-time dose, but there are people who get like epi drips, and we titrate that to effect, not necessarily renal function, but based off of like blood pressure or heart rate or something like that. That's what you'd more likely see. Is there any other questions? If not, you guys are free to go. Thank you for joining me on this early morning. I hope it was informative. Otherwise, the quiz will be next week. It'll be covering the last two sections since the test. So covering ENT and Palm. That'll be that. And then we'll get ready for going into the cardio stuff. It'll be the same as it was last time. So use the Respondus lockdown browser. You have to have your webcam available and all of that. Similar time frame, similar question number and length, all that good stuff. We'll be good to go. If there's any changes, I'll certainly let you know. But otherwise, thank you for joining me, and I will see you guys all next time. Yes, thank you. There's really a note-taking section to respond is I don't know of one, unfortunately. So it's kind of the downside of that. But unfortunately, with this being distant, it kind of is what it is. Otherwise, I'd love to give you some note paper. Yeah, so can you explain why beta 2 agonists work to relax the bronchial smooth muscle? Yeah, so your respiratory tract is lined with these beta 2 receptors, and so when you inhale beta 2 agonists like albuterol, basically by activating the beta 2 receptor, if you recall back in the Intro to Pharm course, we talked about secondary messenger systems, and cyclic AMP was one of those. And basically, beta 2 receptors are G protein coupled receptors. You activate that then causes a downstream effect of increasing adenylate cyclase activity. Cyclic AMP upregulates or is produced, and that causes changes in things like calcium influx and whatnot to relax the smooth muscle. Okay. Again, less calcium coming into smooth muscle, less constriction happens there. So that's typically what you see. Let me know if that did not answer the question, though. Yep, thank you. All right, I'm going to end the stream there. If you guys have any questions, feel free to email me. Otherwise, I will see you all next week.